And if someone's coming in and we're thinking cervical dizziness, I would attack that area first, and see if we can knock down the intensity, duration, frequency, et cetera, et cetera. If we get to the point of, hey, we're not able to get this thing taken care of 90%, 100%, let's open up the clinical impression of what are we missing? What rock isn't unturned yet? And go into the oral facial region. I typically just said, this is what I do. I typically treat that and I assess that typically day two with this, just so I don't leave any rocks unturned. So generally speaking, if you talk about malocclusion, sometimes as a massage therapist, a chiropractor, a physical therapist, a lot of them can work that area and just see if it impacts it. We have assessment tools, we have manual therapy tools, you have exercise tools that can help that as well. If you get to the point that you're like, I think that is a major area, but we're just not getting what we need, that's where that clinician probably should have a team of like, all right, well, do we have a TMJ dentist local, which we have a lot of that. That's like, I think you might need to consult with this person. I think there's a huge input going in. Um, so that's almost the way I look at it. I have a real simple test in the clinic where I use tongue depressors and I get somebody to clench down and ask them where they feel it. And if they don't feel the back of the molars hit, or if it doesn't feel like a little pressure in the joint, or if it's asymmetrical, sometimes I'll use a 1 millimeter tongue depressor and I'll kind of fill in the gap a little bit between the tooth on what that side and see if I can create symmetry. And if we find some major findings with that, then that is a big flag to me to go ahead and make that educate the person. I think this is a major component or something that will help you, and that's my clinical test. I don't think there's a lot of research, particularly with that. To be honest, I mean, I have had people that they'll be 3 millimeters off on one side, and they're like, "Oh yeah, that feels great," and I'm like, "I can't help that. That's too much of a difference. Let me send you to orthodontics. Let me send you to my TMJ guys to tackle that." So I look at it almost as a component where if if you're suffering from this and you're in someone's office and they have knowledge of oral facial work and therapeutic massage and manual therapy, see if they can assess it and then see if they feel like there's a component, because a lot of patients, the patient's going to tell you a little bit like, hey, when I chew or if I talk too long or I'm waking up with a headache in the morning, I'm just tight in my jaw, then those are little avenues that help a little bit more go down that pathway. So I always start I say the cheapest route, like see whoever you're working with there, and before you get into these neuromuscular dentistry, before you get into the maxillary appliances, you're talking about thousands of dollars, or orthodontics is thousands of dollars. So I always say, look, man, I can tackle this. I can tell you if I don't get you better, give me a few sessions. Will have to have orthodontics, or they have to have some sort of maxillary device or mandibular device for either just TMJ itself or to correct that. You're looking at months, 4 months or 6 months or some change, and I don't like waiting around for that. I mean, because yeah, you ought to be able to knock down the otoneurological signs very quickly. That may be kind of fixing the musculoskeletal stuff that might just kind of be picking at it over time. But typically, I don't have to treat the jaw to get the dizziness better. Sometimes you could, but